So we will restart with session two. And session two takes us to that second pillar of CNRD's mission, and that is from discovery to treatment in advancing rare disease therapies. And so as many of you know, there are a few or no approved treatments for many rare diseases. And here in Canada, access to clinical trials or innovative therapies can be inconsistent and often completely out of reach for many. And we've touched on that a little bit so far. In this next session, we'll dive into advancements in therapy development from promising treatments to transformative technology. And so I would first like to invite Dr. Peter Kannu to the stage to talk about moving from discovery to treatment in advancing rare disease therapies. Dr. Kannu is a pediatrician and clinical geneticist specializing in diseases affecting the skin and bones. His research focuses on understanding biologic pathways that influence skeletal growth and maintenance with the goal of improving human skeletal health. At the University of Alberta, he leads efforts to identify novel disease-causing genes in inherited bone and joint disorders. His work includes studying osteofibrous dysplasia, primordial dwarfism, and scoliosis genomics. Dr. Kannu.
Thank you very much for that kind introduction. And thank you to the organizers for the opportunity to come today from Edmonton to talk to you all about rare disease therapies. So I work on two different areas in genetics. Just trying to work this out. So in my laboratory, I study the genomics and the pathomechanisms of rare bone disorders. But in the clinic, I'm also very interested in the advances and the therapeutic trials that are coming for the rare diseases. And this has all, really become available because of the Orphan Diseases Drug Act in America, maybe 20, 30 years ago, which really paved the way for investment into rare disease therapies and what we're seeing right now. So, when I started in genetics, for one, ability to make a diagnosis was probably less than 10%. At that time, chromosomal arrays hadn't even come in. We were using chromosomes and then subtelomeric fish. And lo and behold, we've seen the ability of our ability to make a diagnosis reach about 40 or perhaps even 50%. And we're becoming more and more like mainstream medicine. And the way we practice genetics is also changing. And this has ushered in this whole era of precision medicine, right? So you have a treatment, but you need the right treatment for the right individual, because we know that some people may not respond to therapy X, and some people may do better on therapy Y. And that really ushers in the whole idea of pharmacogenomics in terms of what the body does for drugs. So in the space of rare diseases, we're not so fortunate to have, multiple drug therapies, but we do have a few that are already licensed, which I'd like to talk to you about today, and many more that are coming. So if you look at if you look at therapies for rare diseases, you think about, all these very rare conditions that present with short stature. Now, most of them are incredibly rare. They're probably about over 300, and the nosology keeps increasing the number of subclassifications. But if you look at them collectively, just like most other orphan diseases, they do make up a considerable number of patient visits to the clinic. And the nice thing about the skeletal dysplasias is that you can make a diagnosis on the X-rays. So it's very similar to how people look at the face and look for distinctive features to make a particular syndromal diagnosis. the 3D face imaging that we're talking about, many of the skeletal dysplasias can be classified using the X-rays. And so in some instances, genetic testing is just there as an icing on the cake because it allows you to, it informs reproductive risk counseling. It's also important because some people want to know what they have. But most of the times, the diagnosis may be secure just based on what we see clinically and what we find on the X-rays. So one of the most common conditions that causes short stature is achondroplasia. Many of you would have heard about this condition before. It's a condition where males and females are equally affected, and they generally are about 4 foot tall. And so this is a condition that starts right in birth. The signs start to emerge in the 3rd trimester of life, and then children are born with the features that you see clinically, and the radiological findings are key. The incidence is about 1 in 40,000, and it's due to a change in a receptor gene. So when I talk about a receptor, you can think of like an antenna, a television antenna, and the receptor receives the signal and it transmits it into the cell, and then it allows the cell to do whatever it wants. In this situation, the receptor is called FGFR3, and the signaling is important in controlling the differentiation of cartilage cells, or what we call chondrocytes. And because of the abnormalities in the signaling, we find that bone growth, particularly long growth, does not happen as it should, and you end up with short, long bones. So there are other complications that occur with achondroplasia in addition to the stature, because I recognize that some folks in the community would not consider short stature an issue worth treating. It's important to point out that in achondroplasia, there's a 4% risk of sudden death, particularly in the first year of life. And this is because the bones around the base of the skull are underdeveloped. And so they impinge on the spinal cord, and that can actually cause someone to have paralysis and die. And so that's a real risk that we face with this condition. Children also have the risk of what we call obstructive sleep apnea, and that's because of the shape of their midface, which is different, and that makes breathing much more difficult, particularly if you have enlarged tonsils. The ear canals are narrow, and so you're more prone to middle ear infections. As children get older, they may incur leg bowing, which is largely cosmetic, but we do correct it now with guided growth. And then finally, the bones around the spinal cord are also tight, and so you can get cord impingement and cord pain there. So there are a number of different reasons that one needs to try and look at, what types of treatments are available for achondroplasia. So as I said, the main drugs that we have currently available, the one that has been approved by the FDA for about 5 years, and available, in places like Australia for the last 10, and that is a drug called Viscerotide. And this drug has been incredible in terms of not only increasing someone's height, but because achondroplasia results in short arms, this drug is also normalizing the arm span, which means that little people or children who have achondroplasia are able to perform tasks like personal hygiene much better than they could before. Now, why not stop with one medication, right? Because we know it works. Why not? Why stop there? Why do we need to innovate more? And I come back to that paradigm, just like any infection. We want to have a whole number of different medications that are available for us, because one antibiotic may not work and another may work better in someone else. We just simply don't know which rare disease drug is going to work for which individual with that particular condition. And so currently in trials, a drug that inhibits that antenna or inhibits the overactive signaling, which is being developed by QED. We also have drugs that are very, very specific and target only the particular antenna or receptor that is involved in achondroplasia, and they don't actually affect any of the other receptors. So one would think that you'll be able to lower the dose, lower toxicity, and get a better reaction profile from the drug. One of the problems with the current treatment is that it needs to be given daily, and it needs to be given by an injection. And so there are groups around trying to improve the half-life of the medication. So perhaps you could give it weekly or even monthly, and that would be much, much more acceptable for a little child, as you can imagine, and for the parents as well. The next condition that I'd like to highlight is a condition called fibrodysplasia progressiva ossificans. And this is a condition where folks are born with, again, an overactive receptor. This time the receptor is ACVR1. And what happens in this situation is that when an individual has a soft trauma, so they may, be hit, they may tumble, they may fall off their bike. The flare-up results in inappropriate inflammation that sets off this receptor, and it sometimes results in what we call heterotopic ossification. So that's inappropriate bone formation in the soft tissues. And this diagram here just illustrates a skeleton of a very famous individual with this condition housed in the Boston Museum. And you can see how that bone formation impinges on joints. It finally impinges on your ability to breathe. It impinges on your ability to open your jaw and eat. So this is a terrible condition. It's incredibly rare, about 1 in 2 million. And for many, many years, we didn't know anything about how we could treat this. The gene was discovered back in about 2005, and the first therapies that came in were in the mid 2010s, so about 2014, 2015, and that has resulted recently in the approval of a drug called palovarotene to slow down the accumulation of bone in these folks. The story of palovarotene is very much a Canadian one. It was a Canadian scientist in Quebec that recognized that this particular medication that had been developed by Roche to treat a completely different disease could also work to prevent the heterotopic ossification in fibrodysplasia ossificans. And this was the start of a company called Clementia that went on to do the clinical trials. One of the problems, though, with this medication is that it's a retinoid. And so retinoids are a bit like the Roaccutane, the medications you take for acne. And the side effects include, drying out your mucous membranes, drying your lips, your hair may get brittle, your skin may get very dry and prone to infections. And so at a high dose, some folks find this drug quite difficult to take. And so even though it's the only thing that we have now, it's clear that we need to make inroads and discover more treatments. Finally, a problem with this medication is that if it's given in a young child where their growing hasn't stopped, there's an area of the body in the long bones called the growth plates, and this drug can cause premature fusion of the growth plates, which results in asymmetric growth or perhaps even short stature. So, above all, do no harm, and we recommend that this drug should only be given in individuals whose growth plates have fused. So what's coming along the line? Currently, there are more purpose-designed drugs, such as the ALK2 inhibitors that I've highlighted over there, that work directly on that overactive receptor. So those trials are currently in place. There are also antibody-type drugs that will actually bind to the receptor and block anything else from getting there to activate it further. So it's really exciting times because we do want all these medications to be available because, as I said, we want to have a good repertoire of tools that we have to treat our patients. Now, the final condition that I would like to highlight is a bone condition called hypophosphatasia. And I was talking about fiber ossificans progressiva, where you develop inappropriate bone formation. In this condition, you simply don't ossify your bones. So your bones don't mineralize. And that's what those x-rays are showing there. If you look at that chest x-ray there, what you'll note is the absence of the bones. And if you look at the long bones, what that picture is showing is that the bones are curved or bent. And if you look at that skull, you'd see that shape is not a normal shape, and that's because of the deformation of very, very soft bones. So hypophosphatasia actually is a Canadian condition. It was described back in the 40s by a pediatrician at Kids Hospital. And at that time, it was thought to be a form of rickets, but it didn't respond to therapy. And worse, unlike rickets, it resulted in death. And as time went by, we found that this particular condition was due to a change in an enzyme, which was tissue non-specific alkaline phosphatase. And this particular enzyme plays a really important role in bone formation. It's pretty much the key enzyme that allows the bone to mineralize. And so what happens if this enzyme is not working, you get all this accumulation of calcium that just can't become bone, that accumulates in your kidneys, it can accumulate in your eyes, and you get all sorts of other changes that occur because of this particular condition. So HPP again, aspartase alpha, was actually initially worked on by researchers at the University of Montreal. So this again, there is a Canadian story to it. And in fact, the first clinical trial that was done in Canada was done by Dr. Cheryl Greenberg in Winnipeg, who is one of the world leading authorities on this condition. And what the researchers found is that they could actually make a replacement enzyme. And more importantly, they were able to design a mechanism so that that enzyme stuck to bone and did what it needed to do in bone. And so that allowed you to give a much less dose, which was less toxic and also less expensive for the patient. I just wanted to show you, hopefully the video will work, what this medication does. And maybe it won't. Oh, there we go. So this is a child there. Notice their waddling gait. So this is a child with hypophosphatasia, the infantile form. And you can see how they're not walking very well. And this is a 6-minute walk test that child is performing. And look at this child again after the enzyme treatment, right? What a compelling picture, right? What a compelling picture. If any of us saw that, you'd say, wow, we would definitely want to give the drug to this child. And, you know, that's where I want to end with some of the common themes, right? I think that when you meet folks in Canada, everyone wants to make sure that all our kids and all our adults with these ultra rare diseases get drugs. We definitely agree on that. But what we don't agree on is the more fine print in terms of what is equitable and what is rational and what is fair. And those are issues that I think we're going to be discussing in the conference as the days go by. My first point that I wanted to highlight was that it takes an incredibly long time from the discovery of a gene to a treatment. And that's something we always face in clinic when we give the information out to a family and say, you know, we found a change in gene XYZ. Most families brighten up because they think, well, that's the possibility of treatment. And unfortunately, it takes such a long time for that treatment to become available. I really hope that with, you know, artificial intelligence, we're going to be able to speed that time up, and perhaps we'll be able to purposely make medications much quicker than we've done in the past. Secondly, I want to highlight the enormous expense that the research and development takes for these drugs, and also highlight the role that the universities play in it, because oftentimes these discoveries come from humble researchers working away in the laboratory. They don't do it for the money. They don't do it for the fame. They do it because they're interested in science. And we need to remember when we fund research in Canada, it's going towards projects like this. No matter how small the contribution is, you never know where your discovery is going to end up. I've mentioned already the price of medications, and I think that's one that, you know, we can spend hours discussing, because I'm not sure that there really is a solution to that one. But we certainly need to make a headway into this problem, because it's one that is, I think, crippling our society in Canada right now. And finally, I want to highlight the point that when rare disease drugs are given approval, we often don't know the full picture about the drug. Coming back to the case of achondroplasia, where I said that the drug has been shown to increase stature and arm span, the question that parents want me to answer is, will it prevent the sudden death? Will it prevent the spinal complications? And unfortunately, we don't have that data yet. And one of the reasons we don't have that data is that when drug trials are done, they're done first on older children, right? No one's going to let you experiment on a baby. We generally start with older children before we move on. So there's a considerable amount of time for the full picture about the toxicities, the side effects, and the harms of the drug are known. And it's really important when a drug is released to the public that we are able to study that, may it be through the registries that we've heard before, or there needs to be some mechanism in place that allows us to study the introduction of the drug so that we can make better choices as we move on. And with that, I will say goodbye, and I'm happy to take questions.
Question over here in the room. Maybe I'll bring the mic over to you.
For any of the disorders that you were describing today, or any sort of skeletal disorders, when they're able to be discovered in utero, is there any treatments available or studies going on right now that would look at administering treatment while the baby is in utero?
I think that's an excellent question, because most of these conditions occur from conception and development. And so if you're starting the medications after birth, it may be too late. Now, in the case of hypophosphatasia, the one where you don't mineralize the bone, some people have advocated early delivery so that the infant can receive the enzyme replacement and be given the opportunity to build the bone stronger. Right now, I've not heard of any in utero therapy, but it's possible that as gene therapies evolve, they may be given in utero.
Thank you.
Dr. Kannu, thank you. Okay, we'll move right along. Our second presenter of the second session is going to speak to us about work that they're doing in the manganese transport deficiency zone, targeted therapy for a rare neurodevelopmental disorder. I would like to welcome Dr. Eliza Phillips to the stage. She's a dedicated medical geneticist at the Alberta Children's Hospital here in Calgary. She completed her medical degree at the University of Calgary back in 2017. I'd ask you what animal you are, but we'll just move on. We'll save our own little thing for later on, okay? She followed that with a residency in medical genetics and genomics. Dr. Phillips was drawn to medicine by its unique ability to provide care and support during some of the most difficult moments in a patient's life. Dr. Phillips.
All right. Hello, everyone, and thank you so much for the opportunity to be here. So today I'm going to be describing the journey from gene discovery to the development of a potential therapy for one specific rare genetic disorder, that is manganese transporter deficiency, and particularly focusing on how this work has impacted one of my patients. Okay, it works. So in 2015, there was an international collaboration of geneticists, which also includes significant contributions from some of my colleagues in Calgary and across Canada who are here in the room today. And they published a new genetic disorder that was caused by mutations in a gene called SLC39A8. Now, these geneticists had been following a handful of patients who all had similar medical problems. This included severe developmental delay and intellectual disability. So most of these patients were unable to speak or only had minimal verbal communication and were unable to walk or in many cases even sit independently. In addition, they had recurrent infections, low bone density, and all of them had a striking degree of cerebellar atrophy on their brain MRIs. And so for those who aren't used to looking at MRIs, the cerebellum is the part at the back of the brain, and normally it should fill that space. But as you can see, it appears quite shrunken in these patients. Now, all of these patients, they had undergone thorough genetic evaluation for the time, and despite this, no cause could be found for their medical issues. But genetic testing technology has been advancing very quickly and also 10 years ago was still advancing very quickly. And so in partnership with a Canadian Gene Discovery Research Consortium called Care for Rare, these new sequencing technologies were used and allowed these patients to finally receive a diagnosis of a brand new genetic disorder. And that disorder is manganese transporter deficiency, which goes by a few different names, also SLC39A8 CDG, which is just a bit of a mouthful, so I'm not going to use that term for it. So this is a disorder that impacts the body's metabolism of manganese. We're more familiar with deficiencies in other micronutrients like iron or calcium, but manganese is actually a very important trace mineral that has critical roles in multiple cellular functions. So manganese gets taken up into the cells using the ZIP8 manganese transporter, which also transports zinc into our cells. And in our cells, manganese has multiple different roles, but there's two that I'm going to be focusing on. One is mitochondrial function, and the other is protein glycosylation. So as most of you probably know, mitochondria are the part of our cells that generate energy. And so if we don't have properly functioning mitochondria, the cells don't have enough energy to carry out their essential functions. And so that leads to this widespread cellular dysfunction, and that particularly impacts tissues like the brain that have very high energy needs. And so manganese does play a really important role in mitochondrial function. The other role that it has is in a process called protein glycosylation. And so most of the proteins in our body have these branching sugar structures that are attached to the outside of the protein that are critical for how that protein functions. And so if there's an issue with the formation of those protein structures, a process called glycosylation, then those proteins don't function properly and you get widespread protein dysfunction and cellular dysfunction. And as a result, you get multi-organ abnormalities or dysfunction. And so manganese also has a really important role in this process of attaching those sugar structures and building them, or what's called glycosylation. So now fast forward to 2023, when I met a 10-month-old baby girl who had been admitted to hospital after suffering a significant developmental regression. And so her parents described that even before this particular illness, they had a lot of concerns with her development and her growth. And they described that she was unusually irritable, more irritable than one would expect for a young baby. And then in the weeks leading up to her admission, she had become even more irritable than normal and had developed a fever. And when she arrived at hospital, she had a brain MRI done that unfortunately showed that she had suffered a severe brain injury that impacts critical parts of the brain that are very important in controlling motor functions. And that was in keeping with her loss of motor skills. Now, this particular pattern of brain injury is often goes by the name of Lee syndrome, and it's just a descriptive term that's characteristic of what we see in young children who have very severe mitochondrial dysfunction. For a number of reasons that I won't get into, manganese transporter deficiency was one of the conditions that we were strongly suspecting, and urgent genetic testing confirmed that diagnosis. And then testing of her blood manganese levels showed that they were very low, which is all in keeping with the diagnosis of manganese transporter deficiency. Unfortunately, for many patients with rare genetic disorders, that's where the story stops. They get the diagnosis, and as we've heard, moving from the diagnosis to treatment is a very long and arduous process. Thankfully, with manganese transporter deficiency, having an understanding of the underlying disease mechanism proposed this potential therapy, and that is, the manganese levels are very low, perhaps supplementing with high doses of manganese might have some benefit. And this approach had already been trialed in a couple of patients, which was very helpful in developing and customizing a treatment protocol that could be used locally for this patient. And so we started her on manganese chloride tetrahydrate, which is that sort of pink powder that you see on the slide there. And her blood manganese levels were monitored very closely because there is a risk of developing manganese toxicity. And so over the course of 4 months, her blood levels of manganese normalized. So went to between those red bars, which is the normal range. But we know that just because a number in the blood normalizes doesn't mean that the underlying disease process is actually being treated. And so to try and answer that question, there are a few pieces of evidence that can be helpful in trying to answer whether it's actually having a clinical effect in the patient's cells. And so the first piece of evidence is looking at the pattern of protein glycosylation. So I described earlier that in this condition, there's abnormal glycosylation that results in that widespread cellular dysfunction. And so the diagram on the right is showing an example of the type of test that we use to detect that glycosylation pattern. And so on the right-hand column is the control. So this is showing the pattern that we would see in healthy, normal controls, where they have most of the sugars that sort of fit under that band 4. And that's just showing essentially the pattern of sugars that we see on the proteins. Conversely, on the left is a pattern that we see from individuals who have manganese transporter deficiency, where they have high amounts of abnormal types of sugars. And so after starting on manganese therapy, the patient's pattern completely normalized, which suggests that the manganese is actually being taken up by the cells and is being used in this particular critical cellular function. But I think beyond that, the most important piece is the patient's clinical course. Now, unfortunately, she has suffered an irreversible brain injury, so she does have significant ongoing neurologic symptoms as a result of that, and those are unlikely to resolve even with treatment. But the parents do describe that since starting on treatment, she's a lot less irritable, her sleep has improved, she's a lot more alert and interactive, and she's started to gain new skills again in communication and social development. So these are things that have been really encouraging signs for both our team and the family in seeing those improvements. So where do we go from here? I mean, it's certainly too early to say what the long-term outlook is, and with very small numbers of patients being treated, how much of an impact are we actually having on the disease course? But I think there are some early encouraging signs to suggest that manganese therapy can improve the outcomes for patients who have this very rare disorder. And it is a very rare disorder. Currently, there are fewer than 50 patients with this condition who we know of worldwide. Interestingly, though, most of the patients that we know of so far live in Western Canada. And that's because this disorder is seen at higher prevalence in individuals of Hutterite ancestry. So just a brief bit of background, The Hutterites are an ethno-religious group who live in Western Canada and the Western United States. And Southern Alberta has one of the highest populations of Hutterite colonies. And the Hutterite population is considered a founder population. And so what that means is that it's a genetically isolated population that originally descended from a small number of individuals. And in founder populations, what we tend to see is that there are specific ultra-rare genetic disorders that are seen at much higher prevalence compared to other conditions which are seen commonly in the general population, but which may be essentially unheard of in the founder population. And so this comparatively high local prevalence in what is generally a very engaged population provides us with the opportunity to better understand how effective manganese therapy might be in treating this very devastating condition. And even more promising than what I've described with my patient is some evidence from colleagues working in Saskatchewan who were able to start one child, affected child, on treatment shortly after birth. That child is now 5 and reported to have very nearly normal development. And that's very encouraging. It suggests that maybe if we could start treatment before children have onset of significant developmental concerns or severe brain injury, that this would have a protective effect. And perhaps one day that might open up the door for newborn screening for this condition so that we could detect children and treat them before the damage is done. And so that's all I've got. If there are any questions.
Don't see any questions online, or is there a question in the room? Dr. Phillips, thank you.
Thank you.
We'll keep rolling right along here. And what would all of this conversation be without involving the kids in the conversation? And so our next talk is about pursuing pediatric brain-computer interfaces, or BCIs. Dr. Kinney-Lang is a biomedical engineer dedicated to advancing pediatric brain-computer interface research. As the technical lead for BCI for kids within the Department of Biomedical Engineering at the University of Calgary, he collaborates with researchers, clinicians, industry partners, and families to develop innovative BCI solutions that enhance communication and mobility for children with disabilities. Dr. Kinney-Lang.
All right, thanks. I really appreciate being invited today. You'll get to hear a bit of a different conversation. So I'm working at the technology level of things, and I get to share with you some of the exciting work that I've got to do with some really fun families and kids, like this young boy who I met 5 years ago. And really, how are we taking some of these technologies like brain-computer interfaces and helping adapt them and bringing kids into the conversation as they continue to grow. So rather than hearing it from me, though, I want to introduce you to a family that many people who are part of the Alberta Children's Hospital probably knows quite well, to sort of introduce this idea.
Giving a child the ability to play when they've never played before is it's the biggest happiness that you can have. It brings tears to your eyes. Like seeing her face and the excitement in her eyes I'll never forget that moment. When you have a child who has differences, you try to make everything you can inclusive. Obviously, it's never going to be the full experience that the other kids have, but you always try. Now with BCI, we don't have to change really any of the games, so it's definitely made a huge difference for our inclusiveness. Typical activities that we use BCI, a lot in the kitchen. So Claire likes to make milkshakes and she uses our mix master so she can do all sorts of baking. She also has a pasta maker, so she makes noodles. She has a dart gun, so she and her brothers can whap each other with darts. Adding BCI to our family has just filled our hearts with so much joy, letting her have those typical experiences that everyone else gets. You are changing lives. They say that about so many things, research and everything, but being in this world now, being in the world that I rely on technology for my daughter, I just love this more than I ever could.
So I'm not sure if you caught it in there, but Claire was using just her brain to use a water gun out at their cabin to shoot people as they came by, which is just great. A very fun sort of thing that any kid would like to do, to be a little bit mischievous. So I love showing that video to show off some of the stuff that we get to do. So in my talk today, I'm going to really talk about BCI for kids and like, why do we care about this specifically, and some of the benefits that we get from focusing on pediatrics. And then I'll talk about the BCI for Kids program here in Calgary itself, from the high level and ideas and missions to some previous and ongoing projects, as well as those highlights from it. So I keep talking about brain-computer interfaces, or BCIs, so I'm going to introduce them in 90 seconds or less. So don't worry, we'll go through it pretty quick. Happy to answer questions as people hear about it. So at the high level, really what a BCI is trying to do is directly use your brain to interact with the world around you, to get some desired action or outcome. And the way that we do this is usually through an acquisition of some sort. So you'll hear me use words like EEG. That's just a way to measure activity of the brain from a sensor placed on the scalp. There's implanted systems, trying not to get political. There are certain controversial figures who you may have heard about that in the news, but really we're working with this sort of topical sensors just placed on the scalp itself to record brain activity. So from that, we can kind of pick up these big activities of the brain that are going on. You see me flailing my arms around up here. That's just sort of a big action that we can pick up from the BCI system. We tap into these very stable sort of networks that we expect to be able to drive this sort of process, and that's called signal processing. So you might have someone do something like imagine opening and closing a hand, or imagine kissing, or imagine kicking, and we can pick all of that up with the system itself. So we take that sort of imagined action and we build a classifier from it using some smart algorithms and some machine learning. And we say, okay, what were they trying to do? Were they trying to rest, or were they trying to do their imagined kiss? And that gives us a way to give feedback to the individual to do things like turn on a water gun or turn on a toy car and a bunch of other things, as we'll talk about later. So that in a nutshell is really what BCI is. Take some output from the brain, you do specific action that we kind of train the computer to listen for, and then we feed that into a meaningful application for the kid. And really, why do we care about BCI for kids? Well, children right now are severely underserved in BCI. So this is showing a graph of all the publications in brain-computer interface research. In orange here, that is all adults and all BCI publications over the last 10 years or so. And in blue here is all the publications around kids specifically. It's a small amount, but it's growing. And thanks to a lot of work here in Calgary and across Canada, we're helping sort of lead the conversation in pediatrics. We have a great paper out there that's showing that this is really a moral imperative to try and drive this technology to be inclusive and accessible for kids specifically. Why do I think that it's really important to rethink BCI for kids themselves? Well, kids are an ideal population to use this technology. They are long-term users of it. They can adapt and learn a lot of things, and they really have a lot of opportunity to practice with it. Their brains are capable of significant changes, so they get to learn this system like other access technologies that they might be learning alongside it and open up new opportunities for them. And really, critically, the improvements that we do for kids can help all users. And if I dive into that, I like to give some examples about this. Because in the big BCI world, you have these challenges like things like difficulty in recording data and headrests and movements that you see in kids. And if we answer that question for kids, that leads to better signal processing and outcomes for adults, where you get better designed headsets, you get better artifact removal that can translate well going up from kids to adults. There's also a big issue in looking at this, translating it for kids through variability in development. 2 6-year-olds are definitely not the same, and especially if you have sort of a unique trajectory, it's going to be different. But as we answer that, that promotes greater BCI generalizability overall. It means more people can use it with less issues. Task complexity, kids don't want to do the really boring tasks that are built for adults. We're really good at putting up with a lot. They don't want to do it. What that means is we get to build more intuitive tasks that work better for adults as well, because they can work with the kids. ultimately, that's really that endpoint there. Is those BCI applications are typically only built for adults right now. I don't go into communication, but almost all communication in the BCI world is around spelling and spellers, which has this innate assumption about the ability to spell when you start trying to drive communication, which is a whole other conversation. But what that means is we get to focus more on play and enjoyment and teaching other things like communicative requests for initiating communication, even before you get to that spelling level. So really, there is this need for including kids in this conversation. And that's what we try and do at the BCI for Kids program here at the University of Calgary. And so our aim is to really give children with severe neurological disabilities and their families access to BCI technology as a new means to participate in life. And we do this through some powerful research work. We really try and prioritize play and leisure, and you'll see some patient partner engagements, and really aim for building independence. So I have a couple of highlights that I'll go through. This is not all the work that we do, but I like to show off a couple of the fun stuff that we've been working on. So to start with, I'll emphasize play and leisure because oftentimes when we ask the kids the things they want to do, it's very different than what the adults and the parents want them to do because they like to play games, and they're really interested in things like games, toys, art, as you will see. Perfect. So this is just a collage of some of the fun stuff that we've gotten to do in terms of art with our kids. You'll see actually a number of them have this little robot that we've hooked up to the Brain Computer interface that will roll around on paint. So they will do an imagined action that's usually personalized through therapists with them, something like imagined kicking or imagined kissing, or a variety of other options, and that will move the ball forward through paint, which is then collaboratively controlled, turning it left or right by a parent or a caregiver or a sibling, and they can create these whole variety of collages from this sort of painting. The young boy in the middle there actually started an Instagram with it because he was doing it at home, so he'd upload his different images as he was making them. The young woman on the bottom right is celebrating having won an art competition with her own painting, being able to independently paint for the first time, which was very exciting. Another really popular application is trying to introduce toys and play in a variety of different ways. Here you'll actually see Claire in one of her earliest visits to the Alberta Children's Hospital using her BCI for the first time to turn on a bubble tube. So in this case, she's just imagining trying to turn on this bubble tube. It's translating that brain activity and turning on for her. So she's getting this immediate feedback, very excited about it. And I believe she was 4 at the time when we were doing this. So we are trying to do this with very young individuals. This is another example. This young boy has hooked up a little car to drive forward. And so we set up some blocks so that he could drive the Mario Kart car into those blocks and knock them down. Another big application that kids are quite interested in, and I am as well, is the gaming side of this. So a lot of them want to play video games with their siblings and with their friends, and they want to play independently. And so the question becomes, how do we encourage them and enable them to do that? And so, oh, the video didn't play, but that's okay. One of the young boys here, he has always seen his brothers play video games and typically just has had to watch them. And there's a nice video that isn't starting, that's okay, where he's getting to play the game. It's a knockoff Mario game for the first time while his siblings are watching, which is quite fun. So again, he's using the system to jump while someone is helping control it left and right. And that actually led into an event that I've run a couple of times here in Calgary, as well as with sister sites in Edmonton and Los Angeles, called the BCI Game Jam. And this is really tapping into other communities that want to get involved in supporting the unique kids that we have to make things like this more accessible and drive things like accessibility in gaming. And so the 2022 Game Jam had 68 registrants. There were 17 teams that came together from 3 different continents. So we had people from all over the world participating in this. And it was a 72-hour competition to build a wide variety of games from the ground up to be playable with a BCI system. There were 16 games submitted in 72 hours, which is pretty exciting. So there's a really vibrant, excited, independent gaming community out there who wants to build accessible games to support kids with BCI systems. This is just an example of one of those games that I like to highlight because people tend to think of games as something quite complex or quite different. This was a submission from a developer up in Edmonton called Feels Like Magic, in which he had hooked up a Google Flight Simulator to be able to be played in the browser so that the child could feel like they are flying and moving forward as they are imagining these different actions. And you could set this up with different cities around the globe, and there were different checkpoints that you could start and then stop. And he was a really passionate developer, which is great. This is actually from an earlier submission from a woman named Taylor Nielsen, who is now a developer with me in my new role, which is great. And this won a number of different awards because it was a multiplayer game, initially enabling the child and their caretaker to take turns doing a sport game for the first time called Curl. And they went on to get a couple of grants to develop it from this sort of early prototype that you're seeing to this full-on game that was released on a platform, a gaming platform for anyone to be able to pick up if they were interested. This is completely playable by just the brain. I also like to show it like the trailer. Perfect. Yeah, it's a fun one to check out. So moving on, just conscious of time. Another big project sort of been going on for the past couple of years and has made some really good milestones is looking at sport participation for our kids. So looking at Paralympic sports, in particular the sport boccia, and trying to give independence for them to be able to play sports for the first time. This is work done by Daniel Camadura Marquez, who's a postdoc in the lab, and he's done an amazing job sort of building up this ramp for the first time. And really the objective was to try and enable individuals to play boccia, which right now would require a partner. So our kids who are non-speaking would not be able to participate in this Paralympic sport, to be able to move a boccia ramp on their own, to be able to play this sport. And so you can see this is what it looks like in the Paralympic sport itself, with a number of adapted sort of accessible options, but it still required individuals to participate with you. And so this gives independence by having a completely motorized ramp controlled by the BCI system. It's just an overview of what that looks like. And I want to show briefly, this is the early version that just engineers worked on. So we thought, okay, we're going to work on this. We're going to get it right. It's going to look great. And we were really excited about this working. This summer student just is looking at flashing lights, and it would enable him to rotate the ramp and drop the ball. And we immediately went back to our patient partners, and they're like, yeah, we're going to throw out most of that and give you a much better view of what this could look like. So just emphasizing that nice transdisciplinary collaboration between both patient partners as well as lead Paralympic athletes.
Wait for it to stop
with boccia, to see that this is what our new prototype has looked like, which is now going into that sort of development and testing phase. So it went from that very simple presentation to here now a full one-to-one boccia court where the selections are made in this fan space instead of using just that 3-button selection, so they can encode things like directionality and height at the same time. Lots of fun stuff there. Going through this a bit quick, I know there's lots of videos, so I'm trying to make sure I get through it all. I'm going to emphasize a bit on the rehabilitation side. This is something that stands for functional electrical stimulation. This is work from a woman who's finishing up her master's, looking at building a better experience for our teenagers and our older individuals. She worked with some amazing patient partners to try and tap into the things they're interested in, which is social media. So using a BCI system to scroll through social media to be able to give a better experience for them as they do things like rehabilitation or practice their BCI system. So in this case, the way that it works is they have an imagined action happen when green. You see a green light go. So they're trying to do an imagined hand opening, and then that would eventually scroll the picture itself. So it was done again with a patient partner, 3 of them who helped to build the app alongside us, which was very exciting. And sort of the last highlight that I'll go through really quick is power mobility. This is one of the ones that is typically at the top of the list for families as they come into our program. They're quite interested in this. And this is some of the outcomes from an early pilot, which now we actually did a 2.5-year study looking at how longitudinal effects of learning power mobility skills with this technology can grow and whether or not children can use this technology over time to have independent mobility and to learn those skills, which just got published, I think, 2 weeks ago, which was very exciting. But this is the early pilot study data that we came across there. So this young boy has not moved independently on his own. He has his manual wheelchair onto this sort of trainer, and you'll see that he gets to move for the very first time independently using just his brain.
Shake, 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 shake. Oh, a little bit more. Nice.
You can see how happy he is about that. Again, this is one other video just showing that young boy from the beginning as he's going to his mom. Again, you can see our pediatric neurologist, Adam Curtin, in the background there. So he is independently driving to his mom, which is very exciting for him in some of these early trials. Yeah, lots of fun stuff that we've got to do in the power mobility space, again, integrating play with the BCI systems. So last but not least, just want to emphasize that the team is really a really transdisciplinary team working on a lot of different exciting projects. We have everyone from co-op students who are undergraduates up through postdocs and other individuals working on things from rehabilitation and integration to social media, to music and engagement with music, to fundamental questions of how do we make the technology work better? How do we make it work for each person? How do we calibrate it less? All the way through to integrating it with other sorts of assistive technology they might be used with. So just want to emphasize this is not just one set of person's work. This is a whole team coming together, working on this. So with that, I want to thank our funders, and in particular, I want to thank the children, parents, and families who continue to give their time and energy and input to everything we do to make it possible and worthwhile. So thanks so much. Happy to take questions.
Eli, I guess I'll be selfish and ask a question. I'm
Sure.
curious, sort of like learning a language, and, there's all sorts of evidence and different thought about the perfect age to learn something, learn a language or that. Do you find even within your team anecdotally, or whether there's actual research evidence within your work, that there's a sort of best age or zone to introduce these two with kids?
So it's a complex question because there's different ways that you can control the system. And so you can introduce some of the very simple, basic ones that are more like switch-like very early on. So that's where we've done that down with kids about 3, I think is the youngest that we've ever explored that with, where you get really nice cause and effect that they get to practice sort of engaging in sort of a directed idea, which helps then turn something on and then helping them calm down and relax and maybe sing a song to turn something back off. So we've done that very, very young. And then there's more complex ways as you move into sort of more diverse things that you might want to control on a screen. So if you want to move like a cursor around or select from a number of different options on a screen to watch a video, that might require a little bit more time and energy. And we've only looked at that with somewhat older individuals. So it's not a straightforward answer to your question, but it somewhat depends. So it's out at the moment, but we're trying to push it younger with more.
Feels like a young person's game altogether. You and your team look very young. It's all the young people you're working with. Nice work. Another question over here. Yeah, I'll bring the mic to you.
Do you happen to have a commercialization stream, like a plan for what's next in that step?
Yes. So I wasn't as responsible as Lawrence was in terms of doing disclosures. So there are some commercialization opportunities. A lot of what we do is on the research side and the open source side. There was a company that spun out. I was part of that spin out originally. I'm not active with that company, but that was one of the devices that you saw that's translating things into a switch output that has been spun out through Possibility Neurotechnologies is the name of that company. Separately, I do on the gaming side, I release a lot of what I do for open source consumption. I technically have a company with that. I don't do anything with it. I run my game jam every year and it's essentially working as a nonprofit, but that's like, again, a possibility go through. So there's a lot of commercialization opportunity in the innovation space, but most of us are doing it to try and just engage as many people as possible right now.
How do your patients get referred?
Yeah, that's a great question. So we're actually embedded within the Alberta Children's Hospital itself. And so Adam Curtin, who is a pediatric neurologist, and he is the director and leader of BCI for Kids, he works closely with the critical care units there to get individuals referred to the program. And we've actually set up in the past, I think, 2.5, 3 years, a fully established clinical program that we're still working on getting off the ground effectively. But a lot of that referral is coming from their side, which I don't know much about.
Dr. Kinney-Lang, thank you.
Perfect. Thanks.